Well, I just want to thank you guys for inviting me to come out. Thanks to Drug Science, to Dr. Nutt, to David, and to Graham in the back there. So I'm here to give you guys a practical presentation. Christopher gave a good insight into the evidence, good insight into his practice and a Canadian perspective. I'm here to say, how can you put pen to paper to prescribe to the patient in front of you? Because I know a lot of you guys are specialists, and here specialists are the only ones allowed to prescribe cannabis. So how do you guys do that and fulfill that need for your patient? So I am a nephrologist, and people say, well, how does nephrology come to medical cannabis? I saw a need, and I filled that need, self-taught, and now, coming across the water to give advice to fellow physicians who look towards prescribing cannabis to their patients. So disclosures, no honorarium for this presentation. We already went through my medical director responsibilities. I also wanted to point out that I'm an avid Chelsea fan with tattoos all over my body, and I apologize for all those who support Arsenal, and hopefully I make it out here live after saying that. So the evolution in my cannabis prescribing, it's the evolution that most people go through. I came from McMaster University. That's the father of evidence-based medicine in the world. Okay, that's where evidence-based medicine was invented. So I was grilled in my head to focus on evidence-based medicine. And then other things came up. A need came up when it came to medical cannabis in the cancer center in my local town. And I saw, these little snippets of patients, right, who had benefit from cannabis, and some evidence from states in the US where the opiate risk went down, the deaths from opiates went down. I thought, let me explore this. And now it's like, well, what's in it for me? I'm a nephrologist. How do I add cannabis to my practice? Well, I did see a need for my patients. I did see a need for the cancer patients. And then I saw a need for the general population around me. And that's how my cannabis prescribing evolved. All right, so the objective is a simple approach, make it simple for you guys to prescribe cannabis. How do you put your pen to the paper? That's the next step. And the kind of harm reduction strategies, which I'll hit home after Dr. Blue had talked about a lot of the trials looking at opiate reduction. And we're going to talk a little bit about cannabis use disorder with not a lot of good evidence in terms of therapies, but some promising reviews. So this is kind of the evolution of how I see a patient. You have a case in front of you, a patient in front of you. Indications, contraindications up front before I even consider prescribing cannabis. Do they have some absolute contraindication? We set goals with that patient. And in going through this whole thing, I'm contemplating what are the risks and benefits. I take all my patient encounters from a risk-benefit perspective because as a physician, I look at safety first, right, for my patients. And when you're considering cannabis, right, the evidence we know is not the greatest, right? There is extensive amounts of evidence, but it's not what we regard as the randomized controlled trial, the grade A evidence, right? But it is there. But when you're considering cannabis, is the evidence for the cannabis, the potential benefits and the harm greater than the harm of the actual cannabis itself? Is the evidence for this therapy and the risk for this therapy less than other alternate therapies, their opiates or other things for their current condition? And that's when you can consider cannabis. Then you prescribe it, follow them up, and see their outcomes, and then you can adjust or change therapy accordingly. And this is just the same cycle when you're seeing the patient. And here in the UK, it's every 28 days you have to renew a cannabis prescription. We see patients every 3 to 6 months. So, and I want to hit home that every patient that you see is an N of 1. That's your own trial. It's individualized therapy targeted to that person, and that's how I consider my patients when it comes to cannabis. I had to change my mindset from this body of evidence-based medicine where you're applying a trial to an individual person to every single person in front of me is their own trial itself. All right, so I'm going to do it in the context of this case, a common case of 47-year-old gentleman with a motor vehicle accident and traumatic pain with no neuropathic component who has anxiety subsequently and sleeping issues accordingly. Past medical history of, this is a South Asian population I serve in Canada, the highest South Asian population, so they have heart disease, they have high blood pressure, cholesterol. He had a MI with PCI, high blood pressure and cholesterol, and this is his current medication list. He's on disability, so he's no occupation right now, and he's tried paracetamol or acetaminophen, naproxen, codeine, physiotherapy, chiropractor, and massage therapy for the pain, insomnia, the melatonin, trazodone, zolpidem, and anxiety, just counseling, right? So how do we qualify this patient? We determine what's their primary reason and the secondary reason for considering cannabis. And this is based on local policy. In Canada, we have a list, an extensive list, 15, 20, 30 indications. In UK right now, correct me if I'm wrong, there's only 5 indications: chronic pain, chemotherapy-induced nausea, vomiting, anxiety and depression, MS, and there may be something else that I'm missing in there, but it's not as extensive a list, and different states have different lists. So based on the local policy, you determine the primary and secondary reason. Age appropriateness, greater than 25 in Canada, but that's a gray area because I do have patients, young patients with Dravet syndrome for epilepsy, young kids with refractory epilepsy and not Dravet syndrome, who I'm using cannabis for. So that's a gray area. And then ensure patients are under optimal management. Have they tried other things for the therapy? This is very subjective. And again, I'm getting conflicting ideas that here in the UK, they need to have failed or documented failed 2 therapies before this. And also, you guys can correct me if I'm wrong, but when it comes to determining conventional therapy that they failed, this is very subjective to the physician and the treating physician. So as the specialist prescribing to somebody else's patient, you may work together with that treating physician to determine, in both your opinions, they failed adequate therapy with conventional medications. And if the risk of cannabis is less than the risk of those conventional medications, even if they don't have to go to opiates, because that may be more risky, that you can consider cannabis in this case. And then obviously the contraindications, are they pregnant or actively breastfeeding? The data is still out there, but I'd never prescribe to these patients. Do they have active cardiac disease because of the sympathetic effects of THC? Are they actively having angina right now? And active psychosis is a little bit difficult. It depends on your comfort level of prescribing, because we can still use cannabis for these psychotic patients with good effect. And Dr. Blue and myself were talking today, and I've only had 1 out of the few thousand, 4,000 patients have a psychotic episode on the cannabis that I've prescribed. And their occupation, obviously, if they're in a safety-related occupation, or they're flying planes or driving trains where other people are at risk, that we won't use that in that case. Other occupations, depending on the policy. The next thing to do is establish goals. This is important. And establishing goals not only for symptom control, it's functionality. What are their goals to get back to work, to get back to socializing, to go having a beer at the pub, right? What are the financial goals when that's going back to work? What's the quality of life? And can we reduce their other medications at higher risk? This also determines what strain we choose for that patient. Do they want to be active while on the cannabis? It may be a CBD predominant with certain terpenes that make people active versus those in relaxed if they want to use it later in the nighttime. That helps you determine what strain to use. And now we develop a treatment plan. Okay, for the UK requirements, it's a little different than Canada. You have to choose the right strain profile, and you have to put that out on the prescription form. In Canada, we do a recommended one. We give a patient forms that say, I recommend this, but we don't limit them to the THC and CBD. All right, they can go and choose their own, but they usually choose what we recommend. You choose the right modality. Here, it's only in oil form, and the right dose. So how do we start and how do we dose it appropriately, the CBD and THC, and titrate it up to see the effect? These are just examples of bottles from Afria, which is the partner with Althea. So this is kind of a range of CBD predominant, which has 20 to 25 milligrams per mil of CBD, to the THC predominant, which has 20 to 25 milligrams per mil. They're pretty standardized. And we look at different companies, they have the same ranges of cannabis. It's the difference in buying a Coach purse and a Tony Birch purse is what you're purchasing. It's all marketing on which company costs more. So consider that when you're talking to your patients. Base it based on what they need, what profile they need, not what company they particularly need to go to. And you have different ranges of CBD and THC pre-mixed in 2-to-1 ratios, 3-to-1 ratios, 4-to-1 ratios, 1-to-1 ratios. And we'll talk to you about what the indications where you consider those different ratios in. When it comes to choosing the right strain, you just think simple. What is the reason for it? What are their goals? What are the comorbidities, drug interactions, and then the patient preference? And all from the perspective of a risk-benefit analysis, okay? So, we've hit this home. There's tons of phytocannabinoids. There's tons of other individual chemicals within the plant itself, terpenes being very important. But we focus on, first and foremost, what is the THC, what is the CBD when choosing the right strain, okay? The other ones, preclinical trials to look at their benefits. They do have benefits, but most companies where you're looking to send your patient to are not labeling the concentrations of these for you to make a decision on these. It's only the CBD and THC. And then patients will come to you I want a sativa, or I want an indica. We are leaning away from that. We are focusing mainly on the CBD, THC, and the terpenes, which I'll go into next, and leaning away from the sativa and indica, because the difference between a sativa and indica is very subjective to the patient. And over the years of crossbreeding on the black market, as well as crossbreeding within the licensed producers, that the differentiation between those strains is not there anymore. And it hasn't been scientifically validated what the difference are. So I've given patients things that are labeled by the companies as sativa, and they've gotten extremely sedated from it, right? It all depends. The sativa doesn't tell you what's in it. It doesn't tell you what CBD is in it, what THC is in it, or the other terpenes. It's supposed to parallel that, but it doesn't really give you that information. So first and foremost, the CBD versus THC and the different combinations of those. And secondly, importantly, are the terpenes, because this enhances the THC and CBD, whether to promote a more sedating effect with myrcene, as Dr. Blue had pointed out, or limonene with a mood elevating effect, as two examples of terpenes. And I think this is probably the second most important way of classifying, and we'll start doing it more and more in Canada and here in the UK. In the US, a lot of the dispensaries classify cannabis based on this, but the dispensary model in the US is not regulated, so you don't even know exactly what you're getting, whereas the model in Canada is highly regulated. You know exactly what you're getting in that plant, and the model here in the UK is highly regulated, so you know exactly what you're getting within that plant. And when they start classifying the products with their terpene profile, and we pay more attention to it, and they also start associating it with benefits in certain conditions, we may be able to make recommendations more specifically on these terpenes. But I use it for their additive effect and tailoring it to their goals that they need. All right, so this is just an example of what we use. And Dr. Blue, and myself have also discussed today, because we don't get the chance to talk to each other on how our prescribing patterns are, but we have pretty much the same prescribing patterns, minus a few nuances. But this is, from a safety profile, this is kind of where I start, right? But I'm not afraid to prescribe THC, especially to cancer patient, and even in Alzheimer's. Right? So when you're looking at CBD predominant versus THC predominant, where you're starting off, these are kind of safety nets that I put for myself as a starting point. So if you have mood disorders where patients are maybe higher risk of developing psychoactive effects of THC, I tend to lean towards the more CBD predominant. If they want to stay active, lean towards more CBD predominant, versus those who need appetite stimulation, who need it for sleep effects. But when it comes to Alzheimer's, I try the CBD first. I may evolve into the THC secondary if it's not achieving their goals, but I have to see what their goals are. Do they have Alzheimer's and their aggressive behavior and they need it for sleep, right? That may improve their symptoms. I may stick towards a combined CBD THC and have some THC in there to achieve some of their other goals. And when you do combine them in different ratios, there's some thought that the CBD may attenuate some of the adverse effects of the THC, some of the psychoactive effects of the THC. And we also have access to THCA, which I don't know if it's available here, that doesn't have the psychoactive effect, but still has a THC if it's not combusted. All right? So these are some of the goals in mind, and this is where I, from a safety perspective, start when thinking about a strain for the patient in front of me. Next, I look at drug interactions. And this is kind of a controversial thing because there's not a lot of studies looking at drugs combined with cannabis in terms of safety, but for most part, it's extremely minimal in terms of its interaction. I hardly ever consider it especially only in very particular cases when it comes to blood thinning, and I'll show you that. So THC and CBD are metabolized by the most common pathways. So you look at medications already on, and you say that, can it enhance the effects of THC? Can it enhance the effect of CBD or decrease it? Again, this is very minimal and it's theoretical, and there's a may behind it. It may do this. Okay, I want to hit this home. THC is a inducer of the CYP1A2 pathway. CBD is an inhibitor, but theoretically, and this is how I talk to my patients, theoretically, it can affect these medications. Theoretically, it can affect these medications, either increasing them in the body, enhancing their effects, or decreasing their effects. But I said that none of these are panned out in clinical trials, right? We don't have observations of elderly patients who are on these sorts of medications where they did worse on the combined CBD and these medications. And the more common pathway is CYP3A4 pathway, where 33% of all medications are metabolized by this pathway. CBD is a strong inhibitor of this pathway, so it may enhance some of these effects. I've had a few patients, very few, who are on statin medications, particularly atorvastatin, who came, we started CBD on, and they started getting muscle aches and pains. And we tried them off the CBD, put them back on the CBD, and they got it back again. They got better, and it came back again. And the only thing I could attribute to was it a potential enhancement of their statin medication, leading to some of the side effects. Right? So when I talk to patients, I'm going to go about these things, I have a very clear message that theoretically this may happen, it may cause these, it's something to watch out for, especially with CBD. When it comes to opiates, there was a small study looking at the combination of opiates and cannabis for benefit in pain control, but it showed no additive sedative effects of the cannabis on top of the opiates. So people can stay on their opiate medication while taking cannabis for the adjuvant effect without a significant increase in side effects. And these are some of the studies, so in vitro showing minimal interaction with CBD, THC, and the CYP3A4 pathway. We looked at antiretrovirals with THC with minor decreases. They looked at chemotherapeutic agents with minor changes, and they looked at anti-rejection agents, tacrolimus and cyclosporin, with minor changes in those levels too. Some specific medications where I really discuss risks with my patients is warfarin. And warfarin can be easy because we can monitor the INR, we can leave it in the hands of the family physician because they can increase the level of warfarins, but the level of CBD and THC needed to change the INR is significantly higher than the actual amount we prescribe to patients. So from a safety perspective, it's still pretty safe. Just to give you an example of that, clobazam, they looked at 5 to 50 milligrams per kilogram per day. You're talking about a 70 kilogram male, that's 350 milligrams of CBD at minimal, mildly increasing clobazam. We don't prescribe that. Patients don't get up to that high dose because it costs way too much to use 350 milligrams of CBD per day, right? So we're not achieving any of the high doses that show a lot of these interactions. When it comes to the newer anticoagulants, the DOACs, apixaban or rivaroxaban, I have a frank discussion with my patients and say, it may increase the levels, it may increase the risk of bleeding on these medications. But remember that only 25 to 50% of this medication is metabolized by the liver, so that's where the interaction may happen. If you're consuming cannabis other ways, that may bypass the liver in terms of metabolism, you may mitigate some of these effects. So we have a real discussion with the patients in terms of drug interactions, but it also helps me determine which strain to choose, because CBD has more potential theoretical drug interactions, pretty much no side effects, whereas THC has the cannabis-specific side effects, which are extremely rare to begin with, but less drug interaction. And this is what I talk to patients. And then it comes to patient preference afterwards. The common side effects we all know, the red eyes, the dry mouth, right? But THC has some specific ones that may determine when you choose it or not to choose it. And it's the sympathetic effects. I've had lots of patients come with palpitations. Those patients with myocardial ischemia, maybe they have stable angina, had some worsening in their angina. And when I say lots of patients, I mean 2 or 3, or maybe 3 to 4 out of the 4,000 that I've seen. Orthostatic hypotension, especially if you're using THC at nighttime. I always warn patients that if they get up in the middle of the night to go to the washroom, just be careful. A lot of my patients are elderly, right? And since legalization of cannabis in Canada from the recreational market, my patient population has shifted from 40-year-old average to 60-year-old average. So I'm seeing a lot of patients who with a lot of comorbidities and on a lot of medications who may be at risk for these effects. And then obviously the psychoactivity, which may make me choose CBD over THC in certain circumstances. Right? So now, you thought about their primary condition, their goals in mind, the drug interactions, and the patient preference. You can choose the right CBD and THC profile as a starting point. In the back of your mind, it's always the risks and benefits, right? And then next is the method of consumption. And Dr. Blue has gone over this in terms of Inhalation, whether smoked or vaporized, takes a few minutes 5 to 10 minutes to work, maybe 15 minutes to work, but lasts only a few hours. Whereas oral ingestion, whether it's in oil form or made into an edible or some other form, takes a longer to start, 1 to 1.5 hours, and lasts 6 hours afterwards. It depends on the person, because some of my patients, it only lasts 5 hours, and if they want continuous day coverage, and it takes an hour to start working, at the 4-hour mark, I tell them to take the next dose. And so it's in their system at an equal level, promoting or achieving their goals. And in the UK, it's only going to be available orally, so it's something you need to consider here. Because there's some benefits of inhalation over oral, especially in acute issues. And Dr. Blue and I say that we have a lot of patients who are on both oral cannabis for their background issues or chronic issues, and when they have acute pain or acute issues, acute anxiety, they do an inhaled form for that acute event on top of their background cannabis to achieve their goals, right? And now we have to say, what's the right amount? Because on the prescription, you're supposed to put the CBD and THC profile, you're supposed to put the method of administration, and then you're supposed to put how much do I prescribe this patient? So it's a gram amount or a milligram amount. And what does that mean in oil form, right? So the average ingestion of cannabis or inhalation of cannabis across the world, and this was a study of 930 patients in 31 countries, was around 3 grams a day done recreationally. In Canada, the average prescription is around 2.1 to 2.5 grams a day. In our database, SAIL database, which we have 200,000 patients in the US, it's only 1.2 grams a day. So people do benefit on very small amounts of cannabis. Right, and these are naive patients, 1.2 grams a day. The Canadian ACMPR has both naive and the non-naive patients. And what is the oil, the bottle of oil? It's a 50 to 60 milliliter bottle of oil, depending on the company. It has 5 to 10 grams of cannabis, and it has a concentration of the CBD and THC. Right, they're not all equal to each other. It's just something you need to understand. 1 gram is 30 grams a month. That may be equal to 3 bottles of oil that they're able to order in a 10 gram per bottle, or 6 bottles of oil for that month. And that's what they're going through. That's what you're basing your amount on. And this is a good starting point. 1 gram a day is a good starting point. But you have patients who come in who are not naive, and they're inhaling or ingesting 5 to 10 grams of cannabis a day. And I don't know how a person can take 10 grams of cannabis a day, right? But you have these patients coming to you and expecting your prescription to reflect 10 grams of cannabis per day, right? And that's not self-growing. I only prescribe 10 grams of cannabis a day when somebody has to take it and grow it themselves, because it leaves them some leeway for Mother Nature that may destroy some of their plants, so they have to grow more, and it's in the self-grow era in Canada. But I've had a lot of patients who are on significant amounts of cannabis, and I convince them and show them that if we switch them from their dried cannabis inhalation to vaporization, which actually gets more product, more THC and CBD delivered to them than the smoked form, that they can actually come down on the amount of cannabis they use. If they switch to the oral form, they may be able to come down on the amount of cannabis they use and achieve the same benefit with minimal doses. And we've had good successes in this. Okay, this is some of the understanding equivalence. You know, with the dry cannabis, it's the percentage, it's very basic. With the ingestion, it's the concentration, and this is very key. And although the inhalation is more bioavailable than the ingestion, the amount of cannabis you get through inhalation in the smoke form is a lot less than what you expect. 10% of the THC and CBD you actually get from combusting it. You get 90% of the CBD and THC from vaporizing it, and you get the expected amount from ingestion. It's a little bit more predictable. Okay? So what about the maximum doses? There's no real maximum doses for these, right? Especially for CBD. But when you look at the trials, they use 300 in the anxiety, 300 to 600 in anxiety, 800 in acute psychosis, and 2,500 milligrams in epilepsy. That's an extreme amount. But remember, this is a pure CBD. This is not what's available when you prescribe your patients, which has CBD and a little bit of THC. If you prescribe 250 milligrams of CBD in a 25 to 1 ratio, that's 100 milligrams of THC. That'll throw somebody into a psychotic episode just like that, right? So it's not realistic. For most indications, 5 to 20 milligrams per day as a starting point, and then titrating up from there. I have a rule of thumb that if the person gets up to 60 milligrams in a single dose of CBD and it's not doing anything for them, I review that case to see, are they taking it properly? Is CBD actually right for them, or do they need to more switch over to a THC-based therapy or a combination of both? That is my kind of threshold, right? Because after that, they're using 2.5 milliliters of that bottle 3 times a day, right? They're gonna use 1 bottle every 10 days, 1 bottle being $50 to $100 every 10 days, right? That's not viable from affordability perspective. So you have to be really careful when prescribing to your patients and take this into consideration. It's not practical. Okay, for THC, 10 to 20 milligrams can produce psychosis. So I'm limiting the THC maximum to that point, and sometimes extend up to 40 milligrams. When you look at titration, it's very straightforward. You start off low and go slow. That's been hit home in our heads for a long time being medical practitioners. But you start off small amounts. When it comes to daytime and CBD, you start at 0.5 milliliters, and then every day you go up. You can go up faster, so with every dose you can go up by 0.1 milliliters. Or you could do every day, you can go up by 0.1 milliliters. It all depends on your preference and the patient preference, but it's starting low and going slow. So now it comes down to tolerance. Right? Do these patients develop tolerance? And at the doses that we're prescribing patients, they don't tend to develop tolerance. They may develop tolerance to some of the adverse effects, but not to the good effects. I have patients I've seen over the last 4 to 5 years, and they're using the same cannabis 5 years ago as they're using now. They haven't increased in dose. They haven't asked to increase in dose. They're still using the 1.5 grams a day prescription and consuming the same 0.5, 0.75, 1.5 milliliters 3 times a day without change. But there is a dose-dependent downregulation of the CB1 in high doses of THC. And 9% of patients over the lifetime will develop dependence. It's higher than those who are using it at younger ages and chronic daily users, right? Physical dependence, as defined by withdrawal, which happens very rarely, can appear at day 1 or 2. So people do go through withdrawal when they're stopping cannabis. They get irritated, they have sleeplessness. It's the same thing that may occur with other drugs, but it only appears day 1 or 2, peak effects between 2 and 6, and resolve within a few weeks' time. All right, I'm not gonna go with that. So now that we wrote a treatment plan, we have to see have they reached their goals and objectives, right? And this is the chart I use every single time I'm seeing a patient, right? I'm measuring the benefit versus harm. If there's benefit and no harm, they continue current therapy. Are they reaching their goals maximally? You can increase the dose to see if they get more benefit and find their kind of dose threshold, right? If they increase it and they don't get any more benefit and no more harm, and they increase a little bit more and there's no added benefit, then that's their dose threshold for that strain. If they're getting no benefit, plus they're getting harm, you have to review it. Are they using the right strain? Are they using it the right way? Are they getting it legally and maybe laced with other things, right? So I do sometimes do a urine test in some patients where I suspect that they may be using it laced with morphine or other things that may promote the psychoactive effects or some side effects. Are they having interaction with medications that are promoting the harm, right? And then either decrease it, discontinue it, or change the strain. If they're having no benefit, no harm, then I consider increasing the medication or alternate therapy, alternate strain. And if they're having benefit plus they're having harm, then it's a frank discussion with the patient. Is that what is the ratio? Is it 50% benefit, 50% harm? Is it 70-30, right, 80-20? And have a discussion saying that, do we decrease it and take away some of the benefit to minimize some of the harm, or do we stay at the current dose? And that's a risk-benefit discussion we have with our patients, just like we have with any other medications. Or we consider alternates. So going back to our patient, right, we go through the same list. Primary condition, pain. Secondary condition, insomnia. His age is over 25. He has no contraindications. And from my perspective, he failed conventional therapy for pain and insomnia. He hasn't tried anything for anxiety, but it's there in the background, and it can be helped by cannabis itself. His goals were to reduce background pain during the day and nighttime, reduce episodes of acute pain with certain activities, getting to sleep and staying asleep, as well as decreasing or stopping, ideally, Tramadol or lorazepam. And again, this is my N of 1 patient. So his comorbidities in the background is anxiety and coronary disease. Could the cannabis potentially interact with some of the medications? Potentially. With the cardiac disease, I explained to the patient that the THC component, if we choose that pathway, may contribute to some enhanced sympathetic effects, may lead to worsening angina, may lead to palpitations and something to watch out for, and rare instances, very rare instances, lead to MI. A lot of these symptoms of the sympathetic effect happen around the 2-hour mark after ingestion of cannabis. That's when it peaks in your system. That's where you see a lot of the side effects. And in terms of the anxiety, can we reduce the potential psychoactivity by using a CBD-based therapy? So for him, right, for his pain, a CBD predominant therapy, 25 milligram per mil, starting at 0.25 milliliters, and titrating up using a predetermined protocols. And all those protocols you can use are found in every licensed producer website, or you can develop your own, right? We start at that point. They can use it 3 to 4 times a day. For the acute episodes of pain, I considered an inhaled form, or you can actually just use the CBD in oil form in the background and see if both their chronic pain and their acute pain are treated. And if that's not treated, then you can add in the inhalation form. For their sleep at nighttime, there's 2 approaches I can take to this. Does the CBD alone treat their pain enough that their sleep follows? Or do I have to add in THC for the sedating effect? And in this case, sometimes I have a frank discussion with the patient and say, we can start this way and see what they want, because some patients are afraid of the THC, right? I still reassure them. Or we can say CBD during the daytime 3 times a day, and at nighttime we use a CBD-THC combination, 1-to-1 mix. And then lastly, if these goals are achieved, can we reduce the medications? And I work with our treating physicians to reduce the medications. Okay, I have frank discussions with them to see if we can get off medications. I send notes and call them on the phone and to see if we can achieve these goals, because the treating physician can follow reductions of medications better than I can. I don't have the time to sometimes too. And with follow-up with him, if he falls under these categories, we can either continue therapy, change therapy, or review the system, okay? So I'm gonna go through a basic harm reduction strategies when it comes to, when it comes to opiates, right? This is to hit it home. There was a trial, right? Only 18 patients, mind you, looking at decreasing craving anxiety in those with heroin use disorder using CBD. And the protocol was 4 sessions where CBD was given in session number 1 and in session number 3, and to assess cortisol levels, assess anxiety, and assess craving, as well as other physical attributes, tachycardia, right, pain, and so forth, after cues for heroin use. So these are videos they saw of other people using heroin, needles on the table, whatever it may be, that may trigger their craving or their anxiety. And what they found was over time, session 1, which was 1 to 2 hours after CBD was given, was that there was a decrease in the anxiety as well as the craving. And this was done after 1 hour, after 24 hours, and after 7 days from 1 dose of CBD. All right, so it does harm reduction. And then another recent trial, and this is the last trial I'm going through, in the German registry for a 12-week period, they looked at synthetic cannabis and its effect on pain, as well as reducing opiates and non-opiate medications for this pain. So these patients were separated observationally into nociceptive pain, mixed pain, and neuropathic pain, and followed for 12 weeks. And as you can see here, on the left-hand side, pain went down. That's the average, lowest, and highest pain index for all nociceptive, mixed pain, and neuropathic pain. And on the right-hand side, it reads the same thing. So pain did improve in this study with synthetic cannabis, and it was nabiximols with approximately 15 to 20 milligrams of THC and 15 to 20 milligrams of CBD. But what's more importantly is over the 12-week period, in mixed pain and neuropathic pain, you could see a decrease in NSAIDs, mild opiates, strong opiates, antidepressants, anticonvulsants, and other medications across the board. Unfortunately, in the nociceptive pain, which in my opinion doesn't respond as well to cannabis as mixed pain and neuropathic pain, they didn't decrease as much of their medications. And this is in their maintenance. It doesn't say how many patients completely stopped it, but it said how many patients came down on it over the course of the 12 weeks. And same here, it's a little harder to see, but I want to hit home that in terms of acute rescue medications, same thing occurred. A significant decrease in the use of these medications for rescue dosing. One trial from the Veterans Affairs Canada showed a significant decrease in the use of benzodiazepine and opiate use when prescribed medical cannabis. And this cannabis was given to them by the government with the goal to control the symptoms, and they saw this trend there. okay? So from a perspective here, we see the benefits. We have the tools in place. It's very simple. We keep in the back of our mind risks versus benefit. And from this, we can prescribe cannabis. And knowing that it does reduce harm, okay? So just giving you guys a snippet of the tools you can use and the thought process you can use to prescribe cannabis to the patients in front of you, and the considerations you have to keep in mind about affordability, maximal dosings, and when to have to change or adjust medications accordingly. All right. Thank you, guys.